True or false? IBS, that's irritable bowel syndrome, is just in your head. False. Irritable bowel syndrome is a disorder of gut brain connection. What's one food that unexpectedly worsens gut symptoms, especially in patients undergoing menopause, perimenopause, or polycystic ovarian syndrome? I would say that prunes is a surprising food that can irritate the gut. And specifically, it's a combination of what's in the prunes. True or false? Irritable bowel syndrome only affects women. Hello and welcome everyone to Hormones and Hope, our podcast. And I'm your host, Dr. Chhaya Makhija. And today I'm really charged up to welcome our guest, Dr. Kumkum Patel. She's an Ivy League trained board certified gastroenterologist and practices in the state of California and has built an amazing practice as well as a service incorporating integrative care in gastroenterology. Our topic is gut microbiome and how it's interlinked in women's health. And I'm delighted to introduce Dr. Patel. Welcome, Dr. Patel. Thank you so much for having me. This is a pleasure. And it's fun to get to share my knowledge with other physicians, especially in women's health and all the things that are upcoming in the pipeline. Yes, thank you. So, Dr. Patel, before we get into, the medical aspect of gastroenterology and then how you're going to break that down for us, can you share more about, what exactly do you do? What's your passion like? Why gastroenterology and why women's health? Yeah, absolutely. So, a little bit about me. I am a board certified gastroenterologist and I specialize in irritable bowel syndrome. So, I love all things gut brain connection. I also did a sub fellowship while I was in training in neurogastroenterology and motility, which means I looked at all things IBS, bloating, SIBO. Was trained in esophageal motility as well as anal rectal motility. So when you have trouble swallowing or trouble pooping, I've got you covered. So all of those things. The reason why I went into this is because I felt that one, a lot of women patients are the ones who are, suffering from IBS symptoms. More than 66% of our population is women. The of IBS patients are women, and 14% of the U.S. population actually has IBS. So the fact that 2/3 of IBS patients are women makes it something where women patients are looking for women physicians to take care of them and address how changes in their life, in their lifestyle, and changes in their hormones really affect, their overall health and especially their gut health. Oh, that's impressive. And the focus on women's health has been definitely, I won't say more, but finally getting there in the last couple of years. And you adding to that specific field is just going to help us even more. Absolutely. I'm excited to be a part of all the new things that are coming through the pipeline and with GLPs, the gut microbiome, gut health, and just really understanding where our health comes from and how we can get ahead of it is what's most important. Absolutely, absolutely. So, Dr. Patel, we usually start with rapid fire questions, which are either debunking some myths, true or false. And these are just helping us to get into our deep dive questions in our talk today. So I would love if you can just share yes, no, true, false, or maybe a one-liner if it's in the gray zone rather than just black and white. So question number one, we know there's a lot of talk about mind-gut health or mind-gut harmony lately. So true or false? IBS, that's irritable bowel syndrome, is just in your head. False. Irritable bowel syndrome is a disorder of gut brain connection. What's one food that unexpectedly worsens gut symptoms, especially in patients undergoing menopause, perimenopause, or polycystic ovarian syndrome? I would say that prunes is a surprising food that can irritate the gut. And specifically, it's a combination of what's in the prunes. Wow. Okay. This is a very, very common question. Even though in endocrinology, I don't directly deal with antibiotics, but definitely with gut health. So, a common question asked is should I be on probiotics while I'm talking to them about nutrition? In your view, in your opinion, do probiotics help with irritable bowel syndrome? Yes, for some patients, and no for others. It's got to be strain specific and cause specific, and it's individualized. There's no one bullet because probiotics are about a diversity of bacteria, and so it is not a one-shot solution. So the answer is yes, it does help, but not for everyone. What's one daily habit that truly supports the gut-brain axis? Ooh, diaphragmatic breathing. This is a technique that I teach that helps to calm your parasympathetic nervous system, that really helps to calm the brain portion of the gut-brain disorder. Let's bust another myth. True or false? Irritable bowel syndrome only affects women. False. While women are more often diagnosed and more often the ones with the symptoms, men absolutely suffer from IBS also, and I see them in my clinic all the time. Okay, very impressive. Thank you. So I really need some deep dive in a couple of these, definitely the rapid fire questions. So my first question, since we are talking about irritable bowel syndrome, can you explain our viewers as well as our listeners what exactly is irritable bowel syndrome? And then we get into the nitty-gritty details or nuances of it. Absolutely. So, irritable bowel syndrome, or IBS for short, is actually considered a disorder of gut brain interaction. And it is what we call bidirectional, which means that stressors from the brain will alter how your gut perceives different sensations and stressors. And it alters the movement of the gut, perception of pain in the gut, and also it can cause changes in the microbiome. On the other hand, the gut actually influences the brain also by communicating with it through something called the vagus nerve. That's the primary nerve that runs between the brain and the gut. And the microbiome, which is the bacteria that lives in our gut, are primarily responsible for a lot of the functions and communications. So they help to set mood because the gut bacteria are predominantly responsible for making over 80% of the happy hormones in our body, such as serotonin and dopamine. We also have our immune system living in our gut, so it tells the brain as to how to respond in terms of that. And it also sets mood. And finally, we have our satiety signaling as well. So, gut has a lot of things that happen there, and then it communicates with the brain using neurons and neurotransmitters. So, it's a two-pronged approach, and a disorder or miswiring in this communication causes irritable bowel syndrome. It's like very deep, very insightful. So, I'm going to ask you a few more questions about IBS then. That's irritable bowel syndrome. What are patients complaining when they seek care, especially a gastroenterology care? What are they seeking from you? What symptoms are they coming you to with? And is there any way to diagnose it, be it a lab blood test or a imaging test? Great, great, great questions. So let's talk about what are people coming with. So with the IBS, because it's almost an umbrella type of disorder, right? There are it's a multifactorial disease, which means that it happens due to a variety of reasons, right? So IBS can happen because there may be altered communication in the gut and brain. IBS can happen because there's an alteration in the overall microbiome in your gut. IBS can happen because there is an immune activation happening in the gut. IBS can happen because there is, some type of stressor that has come from the brain that is altering what's going on. So, because of this, the symptoms can be very varied. Okay. And it's a myriad of symptoms. People can come from anything from just bloating to abdominal pain to constipation to diarrhea. Sometimes people have other diseases that also come along with it. So they may have reflux, they may have migraines, they may have headaches, they may have concomitant body pains called fibromyalgia, they may have frequent urinary tract symptoms called interstitial cystitis, they may have underlying depression or anxiety, and all these things are seen to contribute to and be associated with people who've got IBS. And so they can just present with major fatigue, or they may present with changes in their bowel habits. And the Rome Foundation, that is who actually defines irritable bowel syndrome, actually says that there's a 95% positive symptom correlation. So you don't actually have to do any specific blood tests. They're saying that as long as you meet three certain criteria and rule out five others, you can safely say it's IBS. So here's what they say. They say that as long as you are having abdominal pain for at least once a week for the past 3 months, along with changes in your defecation, which means that changes in the frequency of your pooping and the character of your poop, then you have to look to make sure that there's no alarm symptoms, no unintentional weight loss, no anemia, no family history of, inflammatory bowel disease, no family history of cancer. And if all those things are ruled out, and this is not a sudden onset change, you can have a 95%, certainty that it's likely irritable bowel syndrome. And you don't necessarily need to get further testing done. However, I will say, however, there are certain testing that can help rule out IBS mimickers. And there's a lot of IBS mimickers out there, and people should get that testing done because it's very easy to dismiss people's symptoms and say it's just IBS, right? All bloating is not IBS. It can be celiac disease. It can be fructose malabsorption. It can be a high FODMAP diet. It can be an ulcer. It can be bacterial overgrowth. So to call it just IBS is incorrect. And so, yes, you don't have to necessarily do certain testing if the person meets the criteria, but it is prudent and, really important for doctors to make sure that they are ruling out other mimickers of irritable bowel syndrome. That's a lot of expansive discussion that I feel we can have with the patient. So where do they start? Because, they are, so if rather than focusing on men and women, if you're just focusing on a human being, right? And the symptoms that you just mentioned, most commonly they'll get referred to a gastroenterologist, they're getting the workup done, sometimes endoscopy, colonoscopy, ultrasound, CT, and it's all negative. Where are you capturing these details? Is that in your history versus is that in your evaluation? Because that's what I feel we're missing out. Yeah. So please just share how you are approaching your patients in your office. Absolutely. So again, if you are coming in and you've never seen a gastroenterologist, and I'm seeing you for the first time and you're my first referral, not you're coming to see me as a second referral, then you may get an endoscopy or colonoscopy depending on how sudden your symptoms are, if there's any bleeding, if there's anemia, things like that. You may also end up getting certain blood tests, such as looking for celiac disease, looking for the anti-trans glutaminase antibody. You will likely get tested for H. pylori, whether it's during the endoscopy to make sure there's no ulcer. I'll also be looking for anatomical things. Oftentimes people have something called a hiatal hernia as to why they actually have a lot of reflux, or they may have diverticuli and having repeated bouts of diverticulitis as to why they're having abdominal pain. So if you haven't gotten a scope, you may actually end up getting that with me. But let's say you already have, and all of these stuff is negative. Your CT is negative, your ultrasound is negative, your blood work is normal, and you come in, the first thing I want to do is get a good history, right? I want to understand what exactly has happened to you and, in your past, right? What was your childhood like? What has been your past history? Have you had a lot of, abuse? Have you had a lot of anxiety? Have you had family history or personal history of depression? Were you in the military? Were you a victim of child abuse, sexual abuse, domestic violence, right? Are you in a very stressful job, or are you a super type A personality? And people don't expect that when I say, are you a type A personality? Because I have all these very type A women who come in and they're like, I have had my life down to the T, Dr. Patel. And I'm like, I know you have, I can tell. And that level of anxiety that actually provokes in being such a type A and having every last, T is crossed and I is dotted actually triggers a cyclical anxiety response. And that actually basically puts the body into a low dose fight or flight mode. And so a lot of people don't understand that their IBS symptoms actually came from triggers that started in their brain. And so it's important to kind of get a history and understand the person and then figure out, okay, where do we need to go? Do we need to go down the family history route? Maybe this person's parent had Crohn's or, lymphocytic colitis, or this person's family has a lot of, depression there, or this person was previously had child abuse and maybe deep down their brain is storing that trauma in the form of memory neurons, which basically is trying to protect the body and the gut. But they've kind of dealt with it superficially, and now their body is kind of acting out. And so it's really important to get a history, and then, figuring out if the patient or client is open to both, alternative or pharmaceutical or a combination of the two in terms of treatment. That's truly mind, brain, body, and I feel like soul connection because you're teaching them the breath work, which was my next question. So, say if these patients you've identified there's no pathology, be it anatomic or based on the procedures, and now you're pretty certain with the diagnosis that you're discussing with them, which is irritable bowel syndrome. So, what are the first few steps that you teach them or you help them implement, which are, of course, I'm pretty sure transformational? Yes. So the first things I want them to do is learn that this is something that they have to do with their lifestyles and their habits, in addition to if they need certain pharmacological medications to get over it. Now, the first thing I would say is to make sure that people are getting 30 grams of fiber a day. Okay. The ADA recommends anywhere between 25 and 38 grams of fiber per day for men versus women. But let's just stick to an easy number. 30 is easy to do because you have 3 meals a day. You can put 10 grams in each meal, so 30 grams a day. And I want to make sure that people are getting a variety of different things that can provide the fiber for them. If they are also perimenopausal or menopausal, I want them to make sure that they're getting protein to help build their muscle mass. Muscle mass is the primary organ for blood sugar to be taken up. And by keeping the microbiome healthy and building muscle mass, they will keep producing what we call short chain fatty acids. This is the byproduct of what bacteria make in order to do their job, to build the happy hormones, to cause satiety, all of those things. And so, first thing I tell them is the 30 grams of fiber. Second thing I tell them is sleep hygiene. Okay, sleep, even less 48 hours of poor sleep hygiene can alter the gut microbiome. Okay, so getting your 6 to 8 hours of sleep, at least 8 hours is ideal, but between 6 and 8, that's like you're hitting the least amount you can get is 6. And so when you try to aim for that, that helps the microbiome also readjust because it adjusts to circadian rhythm, right? It adjusts to the sun being awake and up in the morning and you being awake and then going down. And so your cortisol levels can also kind of match that. And the last thing I tell them to do is some type of movement. Okay. Moving your body will move your bowels. Okay. Ideally, anywhere between 5 and 10,000 steps a day. If you can't get your 10,000 steps, I know that's like drilled into our heads. Even if you can't get that 10,000, try to get 5, right? You can split that up. It doesn't have to be all 5,000 at once. It can be throughout the day. And getting movement will actually help to reduce your stressors, reduce your cortisol, help those short chain fatty acids be made, and allow for bowel moves to come through, especially if you're constipated, right? So once these three major things are taught, right? Fiber, getting their sleep, getting their movement, getting their water, 60 to 80 ounces of water a day. Then we talk about if there's pharmacological therapy that needs to be added in addition. So if these patients are constipation predominant, there are great medications in different classes that help to reduce bloating, reduce pain, and move the poop along for IBS type C. So there's lubiprostone, plecanatide, linaclotide, and tenapanor. And then if you have diarrhea, you may benefit from elaxadeline or Viberzi or even just a TCA, which is a tricyclic antidepressant, which can help to calm the nerves in the gut. And because it slows down secretions, it also slows down the bowel. So these can kind of augment people's behavioral changes in order to give them the best combination to kind of really get to the bottom of their symptoms and kind of put an end to it. Wow. So you always have to unify. So you have both, the lifestyle strategies for them as well as if they need the support of the pharmacological agents. In our rapid fire, you talked about the diaphragmatic breathing. Is that one of your strategies? And if so, can you explain what that is? Absolutely. Yes. So one of the lifestyle things that I teach is something called diaphragmatic breathing. And that is where we are actually allowing for the parasympathetic nerve, that's your rest and digest nerve that helps to kind of calm the body down. And by doing so, it actually brings the nervous system to calm down so that it's not constantly in a fight or flight. In diaphragmatic breathing, you breathe in through your nose for a count of 4, hold for a count of 7, and breathe out through your mouth for a count of 8. So this is how it looks. Okay. So and usually I do an entire training with them and I sit with them, we close our eyes and we'll actually do, 3 to 5 minutes of that. And I encourage people to do this before each meal and when upon waking as well as upon going to sleep. And so this actually helps people fall asleep and really bring their heart rate and their stress levels down. Now, sometimes people are asking me about food sensitivities and, you know, the stool testing, all that, and we can certainly do that as well, but at least getting your lifestyle, habits in order is the first thing. Yeah, I feel like now, because I teach at the medical school, that the diaphragmatic breathing or the breath work should be a part of our curriculum because no matter in every field. So right now, I've interviewed almost 10 specialists, reproductive endocrinology, gastroenterology, infectious disease, me being an endocrinologist, and then a couple of family medicine doctors, allergist and immunologist, and psychiatrist. They all practice this and they have integrated that breath work in their fields. And it's not just one aspect of parameter which is improved, right? It's so many other benefits that we tend to have. So thank you for sharing and actually demonstrating it. So I wanted to shift, I really wanted to shift now specifically on women's health. And here is also my specific interest and, curiosity with women or females dealing with polycystic ovarian syndrome, as well as the transition of perimenopause and menopause. First question is estrogen and progesterone, or these two hormones, do they have any impact on gut sensitivity or gut contractility? Absolutely. So as you know, in perimenopause and menopause, we have a loss of estrogen and progesterone. Or specifically, your progesterone gets lost first, and then estrogen comes a little bit later. But one, estrogen actually regulates the tight junctions in the intestines themselves, right? So estrogen can actually, help in terms of permeability, right? So you don't want things leaking through. So you hear the words leaky gut. Leaky gut just means that the permeability of the gut has increased and so more things can leak through. Okay. When you have lost estrogen, you have increased gut permeability, which means more things can leak through and can lead to more irritable bowel syndromes, more food sensitivities, and loss of progesterone can lead to more what we call visceral hypersensitivity or nerve hypersensitivity in the gut. So a lot of times people say, oh, it doesn't matter no matter what I eat. I could eat eggs, I could eat oatmeal, I could have pasta. And immediately after I eat, I bloat. Okay. And that's not necessarily a food sensitivity because we now have actually clinically validated food sensitivity tests that are based on antibodies that I actually, can test. But it may be the fact that this is just visceral hypersensitivity. Okay. So nerve hypersensitivity. And so those are oftentimes modulated by estrogen and progesterone. That's number one. Number two, loss of the progesterone prevents the GABA receptors, the calming receptors in your brain from acting out. And so you see more anxiety, more depression, poorer sleep, right? More irritability during perimenopause and menopause. And as these fluctuations are happening, besides them going down each month that you're still having a period, these hormones are having micro fluctuations as well. And so that can certainly be such a major trigger. And so, for some time, obviously after you've ovulated, if you're still having periods, your progesterone is rising because you're not pregnant. And so it's like, okay, let me just figure out if you're pregnant or not. And if you're not pregnant at, day 28, that's when you're roughly day 28, you're having your period, right? And so that rise in progesterone in itself can cause more bloating and more constipation. And then that severe drop in progesterone along with release of what we call prostaglandins causes intestinal cramping. It can cause your period poops. It can cause, a lot of symptoms where people are like, what is it? First I'm bloated, then and then I'm constipated, then I'm having diarrhea. These are fluctuations in our hormones along with other, active metabolites that are causing this. So a lot of times people have that. And, one of the things that's really important to realize is that, estrogen and progesterone, specifically estrogen, is recycled through the GI tract. Okay. So as we, get older, every month, estrogens get conjugated in the liver and they get put together by these bile acids to be pooped out. They get into the intestinal tract and they're supposed to be pooped out. And usually these are excess bad progesterones that are no longer functioning well and things like that. Okay. So it's good if you can, um, you know, get rid of these excess estrogens because in perimenopause, you can get an estrogen dominance if these are recycled too much. Okay. So the other thing is because you're losing estrogen, you're also getting a change in your microbiome and you're getting a lot of bad bacteria. So the more of these harmful bacteria, you don't have a lot of strains of good ones. You also increase the activity of an enzyme called beta glucuronidase. Okay. Beta glucuronidase will split these estrogens from the other chains and allow these bad estrogens to get recycled through your gut rather than being pooped out. Okay. So now you're worsening all of this. So the one way to kind of counteract that is to eat more fiber, right? Because by eating more fiber, you can feed the good bacteria so they can grow and you can reduce beta glucuronidase activity. And by reducing it, you're not going to have as much of the bad, things getting recycled. So it's important to realize that it is all connected. How you get rid of it, what to do with it, is all, associated in terms of your gut and how it controls it. Wow. See, when we address the symptoms of these patients, right? Again, being very specific, polycystic ovarian syndrome, perimenopause, and menopause, it's not just the prescription or a specific metabolic approach, because I deal with the metabolic aspect of, say, polycystic ovarian syndrome, but that discussion of nutrition will also help their impacts of what's happening in the gut in relationship to both estrogen and progesterone. Wow. Any other strategies that are in addition to what you just gave us in the last 20 minutes for these individuals? So yes, they might be needing the support of, some patients need birth control pills, some may need metformin. Other than the nutrition and exercise, mindset training, sleep, and for menopause, hormone replacement therapy. For perimenopause, we're juggling around what kind of replacement therapy they would need. What else is there in your Pandora box, if there is any more, when you approach these patients? So TCAs and SSRIs are pharmacological therapies, and some people are like, "Oh, I don't want to be put on an antidepressant." Well, you have a lot of serotonin receptors, and specifically 5-HT4 receptors, which not only modulate your mood but also modulate how you empty your bowels. So studies have actually shown that people who've got IBS-C really benefit from that. Also, SSRIs, because estrogen modulates serotonin receptors, having a loss of estrogen also leads to lower amounts of serotonin, which can further exacerbate depression. So, getting on an SSRI in perimenopause and menopause can help with hot flashes, a lot of those loss of estrogen symptoms, along with the constipation. It can help with that too. So, getting on a therapy of medication, which can help to mitigate symptoms while you increase your overall health and lifestyle changes, can certainly help. Same thing, the opposite is, tricyclic antidepressants can certainly help in terms of calming down the bowels while you are working on your health interventions. And last but not least, there was a recent meta-analysis that came out that a company called Rose Pharma Incorporated is coming out with a GLP-1 that has been shown to help in IBS, and specifically the pain portion of IBS-C and IBS type M. And they think it's because of how the receptors are actually in the gut. So even getting on GLP-1s can not only help with weight loss, but could help with IBS symptoms. And especially at a time that you're more insulin resistant in perimenopause and menopause, these GLP-1s can be helpful for a lot of those symptoms. I'm glad you say that because I would say in the last 6-7 months, what I've noticed is specifically I'm talking about semaglutide, tirzepatide, the FDA approved versions of it. That previously we were like, oh, you have these gut symptoms, and the way these medications work, they can cause constipation, or they make you give you a sense of fullness, or they may just exacerbate reflux if it's already present. So let's not try it. But many of the patients have IBS symptoms, and this is more specific in the perimenopause, menopausal women that I have. And the medication using GLP-1 receptor agonist for that specific medical indication that they have, it could be overweight, obesity, type 2 diabetes, has actually improved their symptoms. And then I was like, you know what? Yes, this might be IBS. So now it's like more retrospective assessment, and it's more of a clinical assessment. So I'm glad we shared the new piece on the studies that will be ongoing for IBS now.
Yeah, they actually showed that it slows down the motility in the stomach and the first portion of the small intestine, but it didn't actually slow down the motility in the colon. So it's totally fine for the IBS constipation patients to actually take it without worrying that their actual constipation is going to get worse. It will slow down the motility in the top part of their GI tract, but not really affect the colonic transit in their lower colon.
Wow, looking forward to it. Just it's always building up our inquisitiveness and curiosity. Okay. With what you explained, so this is more practical. I have two practical questions for you. Practical meaning how we can help our patients. So, one is when we have identified that they have irritable bowel syndrome, or say I have a patient and she or he has been diagnosed with irritable bowel syndrome, and now understanding their triggers based on the detailed history that you talked about, how do you help them understand what their triggers are? So now getting into their psychological or actual life as a human being, and how do we start help them implement it? Like what would be a couple of things that you discuss for them to accept or be aware that, oh my gosh, I did not realize, but these are the ones that were triggering my symptoms.
Yeah, so a lot of times I ask them when they have their GI symptoms and what precedes them. And, I try to have them do a diary, oftentimes a 2-week symptom and food journal, which can help me and help them understand what's going on. If they find that there was a week, during a certain time period where they were really upset or they had a fight or they were talking to, their spouse or they were talking to an attorney or something stressful, I want them to document it. And we can say, okay, look, this is the time that you had more symptoms and you had the same food 10 days later, but it didn't cause you that same symptom or that same pain. So now you see that it's not necessarily the food that is your trigger, but rather a psychological thing that is making your nerves more hypersensitive to those foods and therefore causing your GI symptoms. So this is something that, it does require a doctor or a coach to work with you. And that's the one thing I do because again, trying to figure this out on your own is something I do not recommend. Okay. You should get someone to help you with this. So because trying to do it on your own, you can eventually get there, but it will take you a long time. So if you want to get real results with someone who's going to actually point things out to you and give you real solutions, actionable solutions, then work with a physician or work with a physician coach. And that's one of the things I will say people should do. And then, frequent visits to see how you're doing on those changes, what needs to be modulated and how they need to be tweaked in order to get the maximal results. So these are two things that I do in terms of my patients and, kind of help them figure out, okay, how are they going to avoid or how are they going to change their reaction to certain triggers or certain stressors and how to kind of get over them and what we can do.
Yeah. That's an amazing investment in our health also, because we can, yes, get a lot of information from the internet, the Google search. Now it's ChatGPT. Who knows? There'll be another AI platform soon again for looking at information. But when we are actually on this health journey to figure out a transformation, to figure out healing, to figure out optimization, I completely, so totally 100% agree that it should be a medical expert, a physician coach, and the right guidance rather than trying to just navigate by ourselves. So, the fiber, right? I wanted to end this with one more last clinical tool or strategy that you recommend. You made it very simple that let's make it 30 grams of fiber, right? For anyone. Can you give us an example of how you incorporate 30 grams of fiber, dividing into, just like you said, 3 meals and 10 grams? So an idea of what your plate or your bowl looks like
Yeah.
to get to the 30 grams at the end of the day.
Okay. My cheat way to go is 2 tablespoons of chia seeds in each set of the meals. Okay. Put it into your water. This is my water cup. Okay.
Oh, I love it. It has nutrition facts too.
It says 500% caring, 500% patient, 400% maternal instincts, 300% hardworking, 200% multitasking, 100% caffeine, 1% sleep, 0% regret. And so those are my, yeah. So put that in your water cup and make sure that's something that you kind of just always have and you're kind of just always sipping on it. If you're not going to be able to get, a salad or broccoli or cauliflower or Brussels sprouts, these are, they are high FODMAP, but they are amazing cruciferous vegetables, which will feed the bacteria in our gut. Okay. So if you're not doing that, chia seeds is a fast and cheat way to effectively get, 2 tablespoons is 10 grams. So there you go. 6 tablespoons, you've got your 30 grams. You can make chia seed and peanut butter, like balls and make them into like a high protein, dip them in chocolate. You can make yourself a little treat at the end of the day. You can put it into your smoothie, you can put it in your salad. And obviously, you want to be able to, diversify it. But if you're not getting your fruits and veggies, and again, you can look up any fruit and veggie and see how much, fiber there is. The cheap way, I would say, is chia seeds.
Oh, that I love that. Yes, I have the same rule here. Chia seeds are like the powerhouses for us. Yes, thank you so much. So, Dr. Patel, if anyone listening here wants to seek care with you or, as a patient, or wants this coaching to be done by you, how can they reach you? Where can they find you? And how can they schedule an appointment?
Absolutely. So you can just visit my website, which is kumkumpatelmd.com. And on the top of the page, it says book appointment. And that's for if you are a California patient. If you're not in the state of California, you can do the coaching program with me. And there's a link for that on my website as well.
Oh, awesome. So, coaching program, anyone in the world can access it, right?
Anyone in the world can do it as well. That's correct. And if you follow me on Instagram, you can find me on doctor.gut_motility, or you can just put my name, Kumkum Patel, in there. And the link to my coaching program is also available in my links in bio.
Oh, sweet. Awesome. Thank you so much. This was, I really loved this discussion. And like I said, I was charged up. I'm even more charged up to share more tidbits with my patients later today. Thank you, Dr. Patel.